Marjan Raad. I'm currently an orthopedic registrar in East Surrey Hospital, and this is an audit I carried out whilst I was in SHO at Darent Hospital in the UK. And thank you for allowing me to come and present this at the International Conference on Arthroplasty and Orthopedic Surgery. So my talk's on the assessment of the efficacy of telephone medicine consultations in dispensing trauma and orthopedic care using the Ashford Clinic Letter Score. So firstly, why are we talking about telemedicine now? I think it's quite clear that the main reason, especially in the UK, that we are moving forward with telemedicine is because of the COVID-19 pandemic, which really made us think of ways to protect patients as well as protecting ourselves from the exposure of COVID-19. And it really made us think of a way to adapt to such challenging times. As we all know, we carry out many clinics a week during orthopedics, and before COVID-19 in my hospital, we actually didn't do any telemedicine at all. But it was a very challenging time, and to prevent exposure and the spread of the disease, we really had to adapt and change the way we do our clinics, which is why we then started to do telephone clinics. So the aim of this study was to see if telephone clinics are superior or equal to face-to-face clinics, to see if the Ashford Clinic Letter Scoring tool is reliable, reproducible and concise, and to see if we can continue doing telephone clinics post-COVID-19, hopefully even a time when things really do improve, and we don't only do it because of the presence of such a virus. So this is just the Ashford Clinic Letter Score. So this is the components on how we score the letters. So it's broken down into, the first one is whether we can make a diagnosis. Secondly, whether we are, for example, able to order appropriate investigations. And the third one is whether we're able to formulate an appropriate treatment plan, whether that is adding a patient to the list for surgery or whether we are discharging them. And lastly was scoring tool based on patient satisfaction, if a patient has specifically said that they were not happy with their telephone consultation. And then this is a guideline for scoring each of those components, and broken down again. That's given each thing. For example, in the treatment plan, if we list a patient for surgery, it's given a 2, discharge is given a 2, treatment plan cannot be agreed, they're scored a 0. So methodology, so what I did was I collected 3 sets of data. The first set was pre-COVID, when we did face-to-face clinics, and then 2 sets during the pandemic when we started doing the telephone clinics. And then we used our online system, patient center, as well as clinic letters to score our letters. So pre-COVID, we did during the first week of March in 2020, which consisted of 60 patients, 36 of whom were follow-up. And then the first week of April in 2020 was our second set of data collection, with again 60 patients, of which 49 were follow-up. Just to note that this was the week when we first properly used the telemedicine, so it was something new for all of the registrar and consultants. And then we decided to do a third set of data collection to see how the staff adapted and if possibly became more confident doing the telephone clinics as well. So we did again collect another 60 patients, of which 60 were follow-up patients. So now moving on to the results. So this is the first graph, which shows the distribution of patients across all consultation groups. So it just shows, for example, in the face-to-face, we have almost an equal distribution of new post-op and routine follow-up patients. And then moving on to the telephone 2, where we actually didn't have any new patients during that time. At the time, we think this could be due to the decrease in either presentation of patients to the hospital at the time, because it was a very high point of the pandemic, or whether we got better at triaging our orthopedic patients in the A&E setting and during the on-call. We didn't actually look at how many orthopedic patients presented during that time. That would have been something that we could have added here. And then this second graph looks at the ability to make a clinical diagnosis across all consultations. So you can see that actually during the telephone too, we are able to make a diagnosis for almost all the patients compared to the face-to-face. And then this one is quite interesting. This is the outcomes from the consultations across all groups. So you can see in regards to those listed for surgery, we have about 6% of patients who were listed in surgery from the face-to-face, but none from the telephone clinics. However, when it comes to discharging, we are able to actually confidently discharge more patients in the telephone clinics compared to the face-to-face. And we did actually bring more patients to follow up from the face-to-face clinics compared to the telephone as well. However, we did order more investigations from the face-to-face clinics, which is interesting. And you can see in the last one, in the routine follow-up, we did bring back more patients for routine follow-up in the first set of telephone consultations, which is interesting. I personally think this is because of the department. It was a very new thing to do telemedicine, so it could be due to it being something new and the confidence of being able to discharge patients over the phone, which is why we then collected the second set of telephone clinic data, and we found that actually we are able to bring less patients to follow up during the second set of telephone data compared to the face-to-face. And then this is just the statistical analysis of the Ashford Clinic Letter Scores from the different clinics. And you can see here that we are scoring better in the telephone clinics compared to the face-to-face. And there was actually a statistically significant difference in the mean scores for face-to-face and telephone letters of a p-value of less than 0.001. So in conclusion, I think our study demonstrated that telemedicine is an effective alternative for treating patients with orthopedic injuries. It can, by the breakdown of the scoring system, provide a valuable diagnosis, allow the organization of appropriate investigations to be ordered, and enable an appropriate formulation of a good treatment plan for patients. Whether that be, whether we discharge them, follow them up, add them to a list, or refer to another specialty. And lastly, the Ashford Clinic Letter Score does provide an appropriate and concise way of measuring these parameters objectively. As well as this, fewer patients required face-to-face examination, which again decreased our exposure and this patient's exposure to COVID-19, therefore all around being a safer way of doing patient consultations in orthopedics. So questions that this arises, whether we shall incorporate telephone clinics post-COVID-19, hopefully whenever that does occur, and are telephone clinics just as safe as face-to-face? I think it's important to think about further studies when doing this. That includes looking at the cost effectiveness of running a fracture clinic compared to telemedicine, time management, whether we are spending more time per patient face-to-face or over the phone, and looking at producing validated outcome scores and patient satisfaction. Just wanted to note that none of our patients expressed any dissatisfaction with the telemedicine, as I couldn't see any of this dictated in the letters. But that's why it's important to actually ask them and look at potential outcome scores for patients. That's the end of my presentation. Thank you.